Hello and welcome to this Medics Voices conversation. Today I'm talking to a remarkable individual, Dr. Niall Downey, or should I say Captain Niall Downey, because he now flies the transatlantic route as an airline pilot. I caught up with him after he had done a teaching session with intensive care nurses. I asked him about his career and the parallels between the airline industry and medicine.
I qualified as a doctor in Dublin in 1993, and through the surgical system then I did the surgical training programme and got my fellowship at the Royal College of Surgeons in 1998 and subspecialised into cardiothoracic surgery. There was 4,500 of us applied for the cadet pilot training programme, and I got in number 11 of 38 that year. Which meant then I was able to leave healthcare and head off to Oxford, and Aer Lingus paid for my entire training and put me on a two-engine commercial jet at the far end of it.
Now, we as doctors think a lot about the comparison between the airline industry and medicine and the whole business of checklists. Tell us a little bit about your interest in checklists, safety, and the parallels between medicine and the airline industry.
Part of the problem is that checklists were added as extra bureaucracy and made life harder for staff and was more paperwork. So obviously it's anything that's a burden will be treated as such. I think that the whole philosophy behind checklists was misrepresented. In aviation, we do checklists because we see it as our final safety net to protect ourselves and keep ourselves alive. So obviously we have more skin in the game.
Is it something among the personality of doctors, or is it the healthcare itself?
I think it's a culture of healthcare itself. A lot of these things, when they're added, are added as an extra layer of bureaucracy, that something went wrong, so here's another step in the process we can add that people then have to try and factor in. Whereas in aviation, we try and simplify things as much as possible. Simple things like, how does communication work? Like, we think communication is very easy. It's actually not. There's three different issues. There's the person delivering the message, there's the message itself, and there's the person receiving the message. And in aviation, we're very focused on, first of all, very simplistic communication, and secondly, closed loop communication. So when you give me an instruction, I read that instruction back to make sure I've got it right. I then action that instruction, and my co-pilot then double checks that I've actually actioned it correctly. So it's a closed loop. We're not finished that message until it's gone through all the various stages.
Communication is equally important in the airline industry and in medicine. I asked him about this and he told me about an interesting acronym, NITS, one that has slightly different meaning for us in medicine.
NITS stands for Nature, Intention, Time Available, and Special Instructions. So to give an example in aviation, if we have an engine fire, we fight the fire. If we get it out, we then have to decide what we're going to do next. So we would then call the cabin crew to pass on a NITS brief. Now obviously, when there's an emergency situation, we have a fight or flight response. So it's a thing in physiology called the amygdala hijack. So the amygdala is a small portion of, at the base of your brain. Whenever there's an emergency, there's a fight or flight response, it takes over, causes a startle reflex, shuts down your frontal cortex and goes back into a primitive fight or flight mode. So we're trained that when we contact the cabin crew, if we start the message and tell them we're on fire, chances are that they're going to get a startle response and they'll not hear anything beyond the word fire. So our approach is that we'll call the cabin crew and say, we've had a problem, I'm going to give you a NITS brief, tell me when you're ready. So it gives them a chance to get over the shock of the fact that there's now an emergency that they weren't expecting, get themselves composed, get a pen and paper, and be ready to take down the message, which they know is going to come in a NITS format. So the next important part in the process is read that back to me. So I'm now waiting on them to close the feedback loop by reading the information back. If they've missed anything or get anything wrong, I feed the information a second time. If they're still getting it wrong, I then move, well, we're in an emergency situation, we're time dependent, so get me the number 2, and we start the process again. But we don't finish the process until we're happy we've got a closed loop, that the message has definitely got through. Because once I finish my communication, I might not be speaking to that cabin crew member again until we're on the ground.
One of the things I was fascinated with was your description of hierarchies and the difference between hierarchies in the cabin crew and hierarchies in medicine. Now, hierarchies, particularly in surgery, can be a problem.
There has to be a leader on board. The captain's in charge. The buck stops with him or her. They take ultimate responsibility. But if there's a steep authority gradient, they'll possibly not get the information. I think we've all got stories of consultant surgeons that we've worked with who didn't take well to correction and didn't appreciate when information that put them in a bad light was fed to them. So there's a very steep gradient there. So human nature being what it is, people are going to protect themselves. If they fed back information that was negative before and got shouted at, chances are they're going to keep their mouth shut the next time. So thus, we try to have a very flat gradient. It's important that it's not totally flat. Someone still has to be in charge. Someone is still the captain. But if you have a relatively flat gradient, it means the most junior cabin crew member can contact me directly in an emergency if necessary and feed me information.
One of the most important messages I got listening to you was the fact that error is acceptable. Tell me a little bit about this concept that error is acceptable, error will happen, and we need to try and prevent it happening.
I think human nature being what it is, error is inevitable. So if error is inevitable and we know we're going to make the error, well, it's no big deal when we do, and there's nothing to be ashamed of when we do, so we can put our hand up. In aviation, we've got what's called a just culture. Now, just to clarify, a lot of people think we have a no blame culture. That's not true. Tomorrow I'm taking a $250 million airplane to the States. If I get something badly wrong, I will be blamed. But the difference is, if I put my hand up and admit to the mistake and cooperate in the investigation, I will not be disciplined and I will not be dismissed. It'll be accepted that I've been flying for 24 years. You haven't made that mistake before. So what was different today? What happened today that made you make that mistake? We do a systems approach. We look and dig into the system and see, well, you obviously tripped over something today. So where was the tripwire and how can we engineer that out of the system? And then how can we educate people to keep an eye out for that in error management in the future? So we see it again as a closed system where we make a mistake, we investigate why it happened, we address it and trying to rule it out in the future and put safety nets in place. And that's the case closed. And our results over the last 50 years have been absolutely phenomenal by applying that. And what I've been trying to do for the last 12 years now is take the exact same principles and process and apply it to healthcare.
Now, you've 24 years of flying, but tomorrow you're going to have to retrain again. Now, this is interesting in medicine. I mean, I don't know how many folk after 24 years go off to retrain. Tell me about that idea and how that works in the airline industry.
Well, we have a series of checks throughout the year. I'm in the simulator twice a year to check that I'm still up to speed. I've got ground training on like a cabin crew simulator. I've got a computer-based sort of technical skills program that we do once a year. And once a year as well, I actually do a line check. So that's when I do a normal flight, but I have a check captain sitting in the jump seat, supervising the whole flight to make sure I'm doing it to the company standard.
It's an interesting concept. I can't see that coming into medicine just yet. If an experienced surgeon had another experienced surgeon in the jump seat watching their surgical procedures, do you think that's something we should be aiming towards?
Well, some people are talking about that. Atul Gawande in Boston, who wrote the checklist manifesto and was the driver behind the WHO checklist. He actually wrote an article in the New Yorker about 4 or 5 years ago suggesting that top-level athletes have a coach. Why don't top-level surgeons? And he brought in the idea of having someone at his sort of level, basically sitting in with him, assisting him in surgery and suggesting ways of doing things better and differently. And he found that extremely useful. I suggested to one of my colleagues a few years ago that it's an idea, like when you're doing something new or novel, that you have someone very senior with you instead of like a basic co-pilot, if you like. Tomorrow, I'm doing my first flight on the A330. I've got an experienced training captain sitting beside me instead of having a normal co-pilot. So it is actually sort of catching on in surgery. And the idea of recurrent training it needs to catch on as well. I get recurrent training 7 or 8 times a year where I have to prove that I can still do things like an engine failure, hydraulic failures and stuff, so that I'm still up to speed with it. And people are happy that I've done it relatively recently. The same principles, especially with simulation now in surgery, are equally applicable in healthcare. And I think there's actually been more progress in the last few years than we dared thought possible maybe 10 years ago.
With your joint interest in medicine and in the airline industry, you've created this company Framework.
Well, I set the company up 12 years ago. We called it Framework Health. And the idea is that in aviation, when something goes wrong, we have a basic sort of framework that we default back into. We already discussed the startle response and like the amygdala hijack from the fight or flight response. We have the same idea that when something goes wrong on board, we have a startle reflex. So to try and counteract that, we have a thing called, say, an Airbus, called the Airbus Golden Rules. So we immediately assess, like, is this life or death in the next 5 seconds? If not, we sit in our hands. And in healthcare, we have ABC, airway, breathing, circulation. In aviation, we've got aviate, navigate, communicate. So we look at the plane and say, is the plane actually physically flying? Is it in a state where it can't stay airborne? Are we flying somewhere safe, or are we pointed at a mountain? Navigate and communicate. Do we need to tell air traffic control if we're going to do something wildly different to what we've actually been sort of told to do up to now? We then look at the systems on board. Have we got our automatics in place? What's the appropriate level of automatics? And is the airplane doing what I would expect it to do in this scenario? So once we've worked our way through that, which maybe takes about 10 seconds, it gives us time to get over the startle reflex and re-engage our frontal cortex, so we can actually now make a more sort of measured response. So the idea is we have that framework we fall back into that applies to every scenario on board, regardless of what the actual underlying problem was.
Well, with the benefit of that experience, if a hospital chief executive was interested in bringing these concepts into practice, what would be the first 3 steps you would go through?
Ideally, we should have more human factors professionals in healthcare. Now, just to clarify, I'm not a human factors professional, but I am a professional who relies on my application of human factors to keep myself and over 300 passengers and crew alive. So if you look at actual human factors professionals, the NHS in the UK, for instance, has about 1.4 million staff. It has approximately 10 human factors professionals working in it, which needs to be expanded a huge amount. That's not going to happen overnight. So what I'd like to do is bring in our system, people like pilots who use human factors on a daily basis, and let us teach what we use. So if I had a chief executive, the first thing I would say is like, have a look at what we're doing. Start with the basics of let your staff see a tracer session like ours. Invest in maybe trying to change your systems. Acknowledge that things are going to go wrong. The biggest thing there is trying to change the culture. In healthcare, I think it's generally been name, blame, shame, and retrain. That needs to change to a just culture. That has to come from the top. So there's been a lot of talk of duty of candor and just cultures in healthcare, but it takes the chief executive to actually walk the walk as well as talk the talk. So the next time there's a big incident in your hospital, you have to actually walk the walk and show that this person is not going to be shamed. This person is not going to be disciplined. This person is going to be welcomed as the most important member of the team today, that they've now got something that they can teach us, that we can now dig into this and work out how we can do this differently. And then after that, then try apply an error management strategy to every member of staff, right from the cleaners, right the way up to him herself, the chief executive. It's a whole team sport. Healthcare is not a spectator sport. Everybody's involved. It has to include all the staff members from the lowest rung of the ladder to the highest, and it has to include the passengers and their passengers and crew in my scenario, patients and their families in the healthcare scenario. The most informed person on the team usually is the patient. They can tell you what's actually wrong. They can tell you what medications they're on. They can tell you if this looks different to what they normally expect. And they have a fair idea about their comorbidities and how different things interact. It's be a very foolish person that would disregard a patient's input.
You've brought this all together in a book, which is due out soon.
Yeah, hopefully that'll be out in May or June of 2023, so it's due out in the next few months. I've decided to try and get a catchy title. Obviously, when something goes wrong, we make mistakes every day, and your first reaction is, oops. So I've called the book, Oops, Why Things Go Wrong. So hopefully it'll be of interest to everybody, but of particular interest to healthcare. And I think that would then bring my 2 careers together, and I'd have contributed something of value back to my original career, which is where my heart still lies, really.
Dr. and Captain Niall Downey, there are very few people with your extensive experience in both. Thank you very much for sharing your insights with us today.